Hi there, students. I'm Criselmer Ducanes, a clinical instructor teaching fundamentals of nursing practice. If you have any question or if you want to clarify some gray areas with regards to our topic today, please comment down below. I would be glad to read those comments. Also, if you want to suggest any topic or content for our next videos, please also write them below. And if you find this YouTube channel helpful, please click the like and subscribe button to keep you updated for new video uploads. So our topic for today is about fluids and electrolytes and acid-base balance. So before we proceed with the topics, let me first present to you a picture. So here we have the list of opposites. So it is related to our topic today, fluids and electrolytes. So when we discuss about electrolytes, we are actually referring to relationships. Some of the electrolytes are inversely proportional, meaning they have an opposite relationship with each other. However, there are also some electrolytes that have similar or the same relationship with each other. So this picture that I'm presenting to you would actually help us as we understand and as we learn the concept on fluids and electrolytes acid-base balance. So now let's proceed to body fluid compartments. So our body fluid compartments are composed of two compartments. So first we have your intracellular fluid compartment, also known as your ICF. We also have your extracellular fluid compartment, also known as your ECF. For your ICF, fluid found inside the cells, and it comprises 2/3 or 70% of the body fluid. On the other hand, your ECF, fluid found outside the cell, and it comprises 1/3 or 30% of the body fluid. So it can be classified into three. It can be an interstitial fluid, which means that this fluid is found in between the cells. We also have your intravascular fluid or your plasma. It is found in your blood components. So basically, it is found in your blood vessels. We also have your transcellular fluid. These are your digestive juices, pleural fluid, water in the renal tubules, and your CSF or your cerebrospinal fluid. So remember, in your extra fluid compartment, we have three classifications, or there are three categories under that. We have your interstitial, intravascular, and your transcellular. So now we'll proceed with the factors of body water distribution. So in infants, 80% of the body weight is water, okay? And in males, 60% of the body weight is water. Males are more muscular than females, okay? So remember, muscle cells can hold water, okay? They can retain water. That is why males have a greater amount of water as compared with females. In females, they only have 50%. 50% of the body weight is water. Females have more adipose tissue than females. Okay, so remember, your fats or your adipose tissue is not compatible with water. Okay, they are not in the same chemical structure. That is why they do not absorb or do not retain each other. Okay, so that's the reason why your adipose tissue or your lipids, that is why if a female person, if a female client has a lot of adipose tissue and fats, he or she has a lower amount of water in the body. Okay, so functions of water. So I divided this into two, the function of your extracellular fluid and your intracellular fluid. For your extracellular fluid, it maintains your blood volume. It also transports gases, nutrients, and other substances to the cells. And for your intracellular fluid, it promotes cellular chemical function, maintains normal body temperature, and eliminates waste products from the cells. So as you can see, the main function of your extracellular fluid is focused on the outside of the cells. Okay? Whereas in your intracellular fluid, the function is focused inside the cell. So, cellular activities. Okay? The cellular, your intracellular fluid's main concern is cellular activities. Activities inside the cell. We also have functions of electrolytes. So, electrolytes promotes neuromuscular irritability. It maintains body fluid volume and osmolality. Distribute body water between fluid compartments. Okay. So, by the way, in your osmolality means it's the concentration. Okay. How concentrated is your fluid? Okay. In the body. So, that is your osmolality. And it regulates acid-base balance. So examples of your electrolytes are like sodium. We have potassium, magnesium, uh, and the rest of the electrolytes. We have actually a lot of electrolytes. So those are the common electrolytes we have. Okay, these are some of the examples of your electrolytes. Okay. So normal values. So your normal values vary, okay, depending on the book that you are using, and sometimes depending on the hospital normal values. Okay. So hospital A has different normal values as compared has different normal values with electrolyte as compared to hospital B. However, the difference is not that very significant. Okay, maybe 0.1, 0.2, 0.3. Okay, but they are within that limit. Okay, so you have here the normal values. So for sodium, that's 135 to 145 megs per liter. For potassium, 3.5 to 5 megs per liter. Calcium, we have 4.5 to 5.5 megs per liter. Phosphate, we have 1.7 to 2.6 megs per liter. For chlorine, we have 98 to 108 megs per liter. For magnesium, we have 1.5 to 2.5 megs per liter. Okay, so remember these normal values. Okay, so below the lower limit, something is wrong. Above the normal limit is there is something wrong. Okay, so be mindful of this normal range or normal values of your electrolytes. Okay, so we have here internal regulation of body water and electrolytes. Sodium and water regulation. So first, thirst. So the thirst is your major control of the actual intake. Kidneys, it's the major organs controlling your output. We have your ADH. ADH means antidiuretic hormone. It retains water in the renal tubules. Okay? When we say diuresis or diuretic, it means that you are excreting, okay? You are eliminating water from your body. So when we say anti-diuretic hormone, that means you are inhibiting, okay, the function of your diuretic hormone. Okay, so meaning you are retaining fluids in your body. We also have your RAAS, okay, your renin-angiotensin-aldosterone system. So we'll be discussing that concept after this slide. So the aldosterone retains sodium and water. Sodium primarily determines the osmolality. It's the concentration. When we say osmolality, it's the concentration of the body fluids. So the RAAS, or the renin-angiotensin-aldosterone system. So this is a simple and an understandable way of discussing your RAS system. So first, the patient experiences low serum sodium. There, you have there. The patient experiences low blood volume, and the patient also experiences low blood pressure. Okay. Then, because the body detects that those particular indicators are low, so there will be an activation of your angiotensinogen. Okay, so your angiotensinogen is being activated by your renin. Then your renin, then your angiotensinogen will be converted into angiotensin 1 by the help of your renin. Then your angiotensin 1 will also be converted into angiotensin 2, okay, by the help of your coenzymes, your CO and E. So your angiotensin 2 will be formed, okay. Your angiotensin 2 is a potent vasoconstrictor, okay, meaning this chemical, this angiotensin 2, constricts the blood vessels. Okay, so we have two functions that there. It resulted into two actions. There is a vasoconstriction and there is an increased aldosterone due to it is the work of your angiotensin 2. Okay, so your vasoconstriction. So if there is a vasoconstriction, meaning the blood vessels constricts. Okay, so the passageway of your blood vessels narrows. Okay, so that increases your peripheral resistance. And if ever there is an increase in peripheral resistance, your blood pressure will be increased. Okay, so the problem of low blood pressure will now be resolved. Okay, another mechanism of your angiotensin 2 is it increases your aldosterone. So the action of your aldosterone, when increased, there is a retention of sodium and water by kidneys and intestine. So meaning, your body inhibits the excretion of water. It retains water in the body. And if the water retains in the body, it would increase your blood volume. Okay? So when the blood volume is increased in your body, it would cause increased blood pressure. Okay? So the problem that you have earlier, you have your low serum sodium, you have your low blood volume, you have your low blood pressure, are now being restored. Okay? Because with the help of your RAS system, your renin angiotensin aldosterone system. Okay? We also have your internal regulation of body water and electrolytes. So second, we have your potassium regulation. Aldosterone and hydrogen ions regulate your potassium levels. Aldosterone retains sodium and excretes potassium. Okay? So remember, sodium and potassium have an inverse relationship, meaning they have an opposite relationship. Meaning if sodium increases, the potassium decreases. Okay? So alkalosis increases sodium excretion. Okay? And the term, if you have decreased sodium, if you have decreased potassium is hypokalemia. When we say hypo, that means low. Okay? When we say kale, means potassium. Imia means blood. Okay? In reference to your blood. So meaning when we say decreased potassium in the blood, it means you are experiencing hypokalemia. Okay? We also have your acidosis, decreases sodium excretion, hyperkalemia. Potassium is the major cation in the ICF. Okay? meaning in your intracellular fluid, in your intracellular compartment. So the main electrolyte that is present inside your cell is your potassium. Potassium is necessary in the conduction of nerve impulses and promotion of skeletal and cardiac muscle activity. Okay, so this is the function of your potassium. So we have here the hydrogen ion concentration. Okay, so first we have here low hydrogen ion alkalosis. Okay, that's the condition, alkalosis. So there will be an increased aldosterone. Okay, so remember, your aldosterone promotes the excretion of your potassium. Okay, so if you have increased aldosterone, it will lead to increased potassium excretion. Okay, so if you have increased potassium excretion, it will result to hypokalemia. Okay, there will be decreased potassium in the blood. Another condition here is we have your high hydrogen ion, called as your acidosis. Okay, so it causes decreased aldosterone. So remember, your aldosterone promotes potassium excretion. However, if it is decreased, it would retain potassium. So there will be decreased potassium excretion. So meaning potassium will be retained in the body. So that will cause hyperkalemia, meaning there is increased potassium in the blood. Okay. Another mechanism that will happen if you have acidosis is that your hydrogen ions enter the cells, thus the potassium shift into the extracellular fluid. So remember, if the hydrogen ion will go inside the cell, so your potassium, which is inside the cell, will go outside, okay, going to your blood vessels. So that would increase your potassium in the blood. Okay. We also have your calcium regulation. So parathormone, thyrocalcitonin, and vitamin D regulate your calcium levels. So vitamin D promotes calcium absorption from your gastrointestinal tract. And calcium promotes neuromuscular irritability, bone and teeth development, and blood clotting. So parathormone elevates serum calcium levels by withdrawing calcium from bones, called your bone resorption. Okay. So meaning, in your bones, you have there calcium. Okay. So your parathormone acts by elevating the serum calcium levels by the process of bone resorption, meaning the calcium in your bone goes to your blood vessels. So that is your bone resorption. Okay. By the way, your parathormone is your parathyroid hormone. Okay, its function is to elevate the serum calcium. Okay, when we say serum calcium, it means that's in the blood. Serum means blood. Okay, so when I say serum calcium, I am referring to the calcium in your blood, the calcium levels in your blood. We also have your thyrocalcitonin, lower serum calcium levels by depositing calcium in the bones, bone absorption. Okay, this process is called bone absorption. So your thyrocalcitonin is another hormone, okay, that lowers your serum calcium levels, okay, by the process of bone resorption. So meaning, calcium from your blood goes to your bone, okay, that's your bone absorption. And the responsible hormone for that is your thyrocalcitonin. Calcium and phosphorus have inverse relationship. Okay, so remember this one. Your calcium and phosphorus have inverse relationship, meaning if the calcium increases, you will expect that the phosphorus will decrease. Okay. So movements of fluids. So we have here passive transport. We have diffusion. diffusion, transport of solutes from area of higher concentration to lower concentration across semi-permeable membrane. Okay, so that's your diffusion from higher concentration to a lower concentration. When we say osmosis, it's the transport of solvent from area of lower concentration to higher concentration across semi-permeable membrane. Okay, so that means from lower to higher concentration. That's for osmosis. So these two mechanisms are under your passive transport. We also have your active transport. So we have, under this, we have your hydrostatic pressure caused by blood pressing against walls of blood vessels. So it's a pushing force. When we say colloid osmotic pressure or oncotic pressure, pressure needs to overcome the pull of protein. CHON, it's protein. Okay, pull or absorb fluid from the interstitial space. Okay, so that's the definition. It's the pressure needed to overcome the pull of protein, pull or absorb fluid from the interstitial space. Okay, so that are the two. These are the two mechanisms under your active transport. Okay. Now let's go to your types of solution. So we have your hypertonic solution. We also have your isotonic solution, and we have your hypotonic solution. Okay. In your hypertonic solution, there is a shrinkage or shrinks cells there. Okay. When you have your isotonic solution, that's a normal cell. Okay. Nothing happens. When it's in your hypotonic solution, cells swell and eventually burst. Okay, there is swelling. Okay, there is cell swelling. Okay, so as you could see in the picture, you could know what happens what happens to your blood. Okay, these are your blood cells. Okay, so if you have your hypertonic solution, your blood cells shrinks. If you have an isotonic solution, nothing happens. If you have your hypotonic solution, your blood cells shrink. Okay? So we have types of intravenous fluids. So first, isotonic solution has the same concentration as the body fluids. Okay? So examples, D5 water. So this is your D5 water. Okay, solution. We also have your sodium chloride 0.9%. Okay? The green one, this is your sodium chloride 0.9%, and we have your plain ringers lactate, so the blue one. Okay, so these are considered as isotonic solutions. Okay, so you have to get familiarized with these solutions. Okay, these are commonly administered in the hospital, especially if the doctor orders for an IV access for your patient. Okay, you have to prepare this solution. Also, we have hypotonic solution. So has lower concentration than the body fluids. Okay, so example is your sodium chloride 0.3%. So this one, okay, this one is a sodium chloride 0.3% and a hypotonic solution. We also have your hypertonic solution, has higher concentration than the body fluids. Examples, D10 water. This is your D10 water. Okay. We have also your D50 water, this one. D5LR, the pink one. And we have your D5NM. Okay. These are examples of your hypertonic solutions. Okay. So you have to familiarize with those solutions. Okay. So now let's proceed to the discussion regarding your fluids and electrolytes. So I have made a technique here for you to remember. Okay, so we have the piso. Okay, piso, we have to remember piso means P stands for potassium, I stands for in, S stands for sodium, and O stands for out. Okay, so what do we mean by this? Okay, so remember, potassium is in. Okay, meaning potassium is inside the cell. Okay, meaning the abundant electrolyte that is found inside the cell is your potassium. Okay, so you expect that there will be a lot of potassium inside your cell. On the other hand, your sodium is out, SO, meaning the sodium is most of the sodium are found outside the cell. Okay, so they are abundant in that area. Okay, so remember that one. Potassium in, sodium out of the cell. Okay, so first we have your sodium imbalances. So we have your hyponatremia, meaning it's sodium deficit or decreased sodium in the blood. Okay, so it is caused by sodium loss or water excess. So causes, what are the causes? Diuretics. Okay, as what I have mentioned, when we say diuretic, it means that it helps excretion of water from our body. It eliminates excess water from our body. So it is considered as one of the causes of your hyponatremia, because if you eliminate water from the body, your sodium might be washed out. Okay, it it follows the water. Okay, so that's it. That's the mechanism. So administering too much diuretics to your patient could actually cause hyponatremia. Low sodium diet. Of course, if you do not eat sodium, if you do not eat food with sodium, it could cause hyponatremia. Decrease aldosterone secretion. Okay, as what I have mentioned, when we say aldosterone, it promotes sodium absorption and excretes potassium. Okay, so if you have decreased aldosterone, so your sodium will not be absorbed. Okay, that would cause hyponatremia. Edema, of course, of excess water, and ascites. Burns, of course, when when the person is burned. Okay, so the body releases fluids. Okay, the body releases fluids, so your sodium also are uh, are washed out. Okay, during your burn, if the patient is burned. Okay, diaphoresis, of course, you are losing water, and that includes your sodium. Okay, we also have your hypernatremia. It means sodium excess or edema. It means you have a lot of sodium in the blood. Okay, increased sodium in the blood. So sodium and water excess results to edema. So causes. By the way, when we say edema, it is the accumulation of water in any part of your body. Okay, for example, in your feet. Okay, so your feet swells, and that's edema. Okay, because there is an accumulation of fluid there. Okay, so hyperventilation and diarrhea. Okay, that would cause your hypernatremia. Okay, high sodium intake, sodium tablets. Okay, that would increase your sodium in the blood. Water deprivation. Okay, dehydration promotes your hypernatremia. Okay, so if a person is dehydrated, expect that the sodium level is increased. So hyponatremia versus your hypernatremia. In your hyponatremia, increases your ICF volume. So meaning your cells swell. Okay. When you say hypernatremia, decreases ICF volume, meaning the cells shrink. Okay, so remember that one. When we say hyponatremia, the cells swell. Okay, when we say hypernatremia, the cells shrink. Okay, so next we have your potassium imbalance. So hypokalemia or potassium deficit, or there is a low level of potassium in the blood. So characterized by decreased neuromuscular irritability. So everything is low and slow. So you would think that any reaction that is slowed is caused by your hyponatremia. For example, decreased bowel movement. Okay, the patient is somnolent. Okay, that would cause hyponatremia. The patient has no energy. Okay, low and slow. So these are examples of your hyponatremia. So the causes, we have your decreased food and fluid intake. So you starve. There is starvation. So that could specifically if you lack potassium in the diet. Increased loss of your potassium and shifting of potassium into the cells. Okay, so potassium from your blood goes inside the cell. Okay, so meaning there is a limited number of potassium left in your blood vessels because it goes to the cell. So that would be a shifting of potassium into the cell. We also have your hyperkalemia, potassium excess, or there is an increased level of potassium in the blood. So characterized by increased neuromuscular irritability. So everything is fast and high. Okay? Everything is high and fast. So that's the characteristic of your hyperkalemia. So the causes are excess dietary intake of potassium-rich food, excess parenteral administration of potassium, and decreased excretion of potassium, and shifting of potassium out of the cell. So these causes are self-explanatory, and it could actually increase the potassium levels of your blood, potassium levels in your blood. So we now go to your calcium imbalances. So we have your calcium hypocalcemia. There is an increased cell membrane permeability which results to increased neuromuscular irritability. So everything is high and fast. Okay, so the same with your hyperkalemia. So everything is high and fast. So you could expect, for example, there is excitability of neuromuscular reaction. For example, there's a seizure. Okay, the patient is diaphoretic. Okay, the patient experiences tachycardia. Okay, so that's an example of your that's an example of the signs and symptoms of your hypokalemia. So the causes are, of course, there is a decreased ionized calcium, excess loss of calcium from the body, and inadequate dietary intake of calcium rich food, and decreased calcium absorption. Okay, so these are the causes of your hypocalcemia. We also have your hypercalcemia, meaning there is a decreased calcium in the blood. So decreased cell membrane permeability, which decreases neuromuscular irritability. So everything is low and slow. Okay, so the same signs and symptoms as with your uh, hypokalemia. Okay, decrease potassium in the blood. So the causes are calcium loss from the bones. So meaning the calcium from the bones goes to your bloodstream, okay, blood vessel. So that would increase your calcium in the blood. Excess intake of calcium, hyperparathyroidism, okay, Remember, your parathyroid hormone or your parat hormone, the main function of that hormone is to increase the calcium level. So if you have a hyperfunctioning of parathyroidism, that would increase the level of your parathyroid hormone, and it would eventually increase the level of calcium in the blood. We also have your hypervitaminosis D. Okay, this could be a factor why a patient is experiencing hypercalcemia. Steroid therapy could also contribute in the increasing amount of calcium in the blood. Okay, so let's go with magnesium. So we have here hypomagnesemia, which means there is a low level of magnesium in the blood. So magnesium inhibits acetylcholine release. Acetylcholine is a neurotransmitter, okay, in the brain. Okay. So in hypomagnesemia, there is increased acetylcholine release, which results to increased neuromuscular irritability. Okay, so remember your acetylcholine release, or acetylcholine, your acetylcholine uh, is a neurotransmitter that excites. Okay, it's excitatory neurotransmitters. Okay, so it's active. So if you have hypomagnesemia, it inhibits the acetylcholine. That means there is an increased neuromuscular irritability. There is an increased acetylcholine release, which results to increase neuromuscular irritability. So everything is high and fast. So causes: prolonged malnutrition or starvation, malabsorption syndrome, okay, because you could not absorb magnesium into your body. We have your hypercalcemia, okay, because your magnesium and calcium are inversely proportional. So if the calcium increases, your magnesium decreases. Alcohol withdrawal syndrome and draining fistula. Okay. So these are the causes of your hypomagnesemia. We also have your hypermagnesemia. There is decreased acetylcholine release, which results to decreased neuromuscular irritability. So everything is slow and slow. So causes: excessive intake of magnesium containing antacids, because there's a magnesium content, so it could probably increase the amount of magnesium in the body. Renal failure and diabetic ketoacidosis. Okay, that would increase the magnesium in the body. So in capsule, we have here hypocalcemia and hypomagnesemia. Everything is high and fast. So that refers to the signs and symptoms of these following electrolyte imbalances. Hypercalcemia and hypermagnesemia, everything is low and slow. So that refers to the signs and symptoms of these electrolyte imbalances. Okay, so remember this concept. Okay, let's now proceed with your acid-base imbalances. So we have here the arterial blood gas, or your ABG. So we have normal values that you need to memorize. Okay, so blood pH, we have 7.35 to 7.45. Above and under that normal values is considered abnormal. Okay, so your PO2, we have 80 to 100 mmHg. For your PCO2, 35 to 45 mmHg. And your bicarbonate, or HCO3, we have 22 to 26 mx per liter. Okay, so remember these values. Okay, so for your interpretation, So pH less than 7.35, it means the patient is under acidotic state or acidosis. pH more than 7.45, alkalosis. PCO2 less than 35, it means the patient is in alkalotic state or alkalosis. PCO2 more than 45, acidosis. HCO3 less than 22, that's acidosis. And HCO3 more than 26 is alkalosis. So if pH is 7 and below or 7.8 and above, death occurs. Okay, that's a very dangerous value for your pH. Okay, so be mindful. If it's below 7 or above 7.8, that could cause death of your patient. So if pH and PCO2 are primarily affected, respiratory acid-base imbalances will result. If pH and HCO3 are primarily affected, metabolic acid-base imbalances will be experienced. So we'll be discussing more of respiratory and metabolic imbalances in the following slides. So for your respiratory acidosis, which means carbonic acid excess. Okay, so remember your carbon is acid. Okay, so if you have increased carbon dioxide in the body, so the body is experiencing an acidotic state or acidosis. So caused by failure of the respiratory system to remove carbon dioxide from the body fluid as it produced in the tissue. So disorders that lead to hyperventilation results to retention of your carbon dioxide. Okay? We also have your respiratory alkalosis, known as your carbonic acid deficit. So caused by loss of carbon dioxide from the lungs at a faster rate that is produced in the tissue. So disorders that lead to hyperventilation results to excess loss of carbon dioxide. Okay? So we have here a respiratory acid-base imbalance cycle. So for example, your patient experiencing hypoventilation, meaning there is a shallow respiration, okay, below the normal rate. So hypoventilation. So if the patient is experiencing hypoventilation, there will be retention of carbon dioxide because that patient could not exhale that carbon dioxide. Then if there's retention of carbon dioxide, there is decreased blood pH. Okay? Meaning, if you have decreased blood pH, you will be experiencing acidotic state or acidosis. Then the patient will experience respiratory acidosis. Then the body will compensate by hyperventilating. Okay? So the body would detect that this particular patient is experiencing respiratory acidosis. So that would increase the respiratory rate to eliminate the carbon in the body by way of hyperventilating. Okay? So if there is hyperventilation, so there will be loss of carbon dioxide. And if there is loss of carbon dioxide, there will be increased blood pH. So meaning if the blood pH is increased, so the patient will be experiencing an alkaline state or alkalotic state or alkalosis. Okay? If there is an increased alkaline in the body or the patient experiencing alkalosis, so that would result to respiratory alkalosis. Okay? And if the body detects that the patient experiencing respiratory alkalosis, it would try to balance, okay? It would try to balance your pH level by way of hypoventilating. And the cycles goes on and on until the body restores its acid-base balance, okay? So remember that one, okay? That's the respiratory acid-base imbalance cycle. We also have your metabolic acidosis. So it's bicarbonate deficit. So results from abnormal or fixed acids or loss of base. So assessment, we have here headache, mental dullness, Koshmal's breathing, and hyperkalemia. Okay? So these are the common assessment that you will note if the patient is experiencing metabolic acidosis or bicarbonate deficits. Now we have here metabolic alkalosis or your bicarbonate excess. So results from loss of hydrogen ions or addition of base to body fluids. Assessment, we have here hypoventilation, mental confusion, dizziness, numbness and tingling of fingers and toes, muscle twitching, tetany and seizure. So these are the assessment that you will note when the patient is experiencing metabolic alkalosis or bicarbonate excess. So in a nutshell, so this is how to differentiate between metabolic and respiratory acidosis or alkalosis. Okay. So when the patient is experiencing respiratory alkalosis, the pH is increased, the carbon dioxide or your PCO2 is decreased, and the bicarbonate is normal. Okay? That's the pattern. When we say respiratory acidosis, the pH is decreased, the PCO2 or the CO2 is increased, and the bicarbonate is normal. In your metabolic alkalosis, the pH is increased, the carbon dioxide is normal, and the bicarbonate is increased. In your metabolic acidosis, the pH is decreased, the PCO2 or the CO2 is normal, and the bicarbonate is decreased. Okay. So arterial blood gas analysis. It is commonly ordered to the client with COPD, pulmonary edema, ARD, or acute respiratory distress, and MI, your myocardial infarction or your pneumonia. Also used for non-emergencies, such as weaning from ventilator. Helpful in the assessment of children who are acutely ill with either pulmonary or non-pulmonary disorders who requires an artificial airway. So we have here Allen's test. The main indicator of your Allen's test is to assess adequacy of blood supply to the client's non-dominant hand. Okay? So before you perform your Allen's test, before you perform your ABG, or before the extraction of arterial blood, you have to perform Allen's test first. Okay? So the steps are, first, have the client open and closed fist a few times. While fist is clenched, simultaneously occlude both radial and ulnar arteries. While arteries are occluded, ask client to slow unclenched fist and relaxed hands. The palm should be pale from lack of arterial blood flow. Then release the pressure over the ulnar area. The palm should turn pink within 7 to 15 seconds. That means it is positive Allen's test, indicating that arterial circulation has resumed. If that does not happen, you will need to select another site. Meaning, if it is not positive for Allen's test, you have to look for another site of your Allen's test, or for your ABG extraction. You have to look for another artery or arterial site for your ABG extraction. So this is how you perform your Allen's test. So the test is done to assess the arterial blood flow to the hand. This test can be performed for either the ulnar or radial artery. So you have to occlude both the ulnar and the radial artery. Okay? So the accessible vessels for arterial puncture. So we have a lot of arterial sites. Okay? First, we have your radial artery, superficial, easy, compressible, and with good collaterals with ulnar artery. Ideal vessel for arterial puncture. So it is commonly used, okay, when a nurse or a doctor wants to obtain a specimen for arterial blood gas analysis. We also have your brachial artery, femoral artery can be used, temporal artery, dorsalis pedis artery. So I think that's it. So remember that we have 5 accessible vessels for arterial puncture for your ABG extraction. Okay? So I believe this is the last slides of our discussion. So again, if you have any question, you may ask by commenting